Thank you. This is a bit of a busy slide, but I basically wanted to bring you through what breast cancer is, how we diagnose it, generally how we treat it surgically. There are some innovations that we're working on even on the surgical side, the kinds of treatments that you get after in terms of chemotherapy, and innovations that we can look at in terms of the immune system, changes in radiation, some of the things we're doing with the biobank, as well as out there research ideas that we're launching in terms of both quality side effects such as lymphedema and innovations with regards to probiotics. So what is breast cancer? If you look generally at a breast, it's mostly fat with some ducts that kind of run all the way through and up into the nipple. And if you take a transection of that duct, it's lined 1 or 2 cells thick. And those cells make a bit of fluid and are useful for when the breast is producing milk. But if those cells grow too quickly, more than they should, the cells grow and die and fill the milk duct with these abnormal cells. And they can continue to be so abnormal that they even look cancerous. So we call that duct cancer in situ. They're malignant looking, but they're confined to the milk duct. That's a stage 0. But over time, they'll learn to grow through the milk duct into the surrounding fat where there's lymph channels and it can spread. And that's where people are at risk of having cancer spread elsewhere or die of their disease. So how do we detect that? Fast-growing cells that grow and die get replaced with little flecks of calcium. So if you do a mammogram, you actually can see the early stages probably best with that imaging modality, even more than you can with MRI or some other technologies. And you can see it turn into a little mass on the imaging as well. So any of you that have had these mammograms know that they're less than ideal comfort-wise, but there are even some changes that are as practical as rounding out the plate that you sit on so that it doesn't dig into you for the however long it is that you're being compressed. And at St. Joe's, they now have acquired a new machine where you self-compress. So actually the radiologists find, ironically, that you have better compression when patients self-compress than if you them for you. So they're getting a better image. You're trying to do such a good job. People don't want to do this because they think it causes cancer, because it's an X-ray. And I completely understand that. And their best evidence to prove that that's not true are the numerous trials where we looked at the efficacy or the effectiveness of mammograms at detecting cancer. And when we look at those people that had mammograms versus the people that didn't, there was no increased risk of other cancers in the people that were being screened, but there was a significant reduction in breast cancer-specific deaths in the screened versus the unscreened. So it still remains our mainstay tool at detecting both precancer and invasive cancers. It's not great for everybody. It's not very good for young people because when you're young, you're quite dense, and as you get older, you get a little bit less dense, and so you fall somewhere on this spectrum. Now you can imagine if you're a level 4 really dense type breast tissue, it's going to be really hard to see anything. Like I say, it's like a cloud, like a whiteout, and picking out something from there is pretty challenging. And so this was where we were often stuck with doing MRIs, but some of our radiologists here at St. Joe's have been quite innovative in bringing new technologies, including contrast-enhanced mammogram, where they do an IV, and the contrast actually goes like an MRI, is like that too, but it shows really specifically where things are actively working. And you can really see the difference from the whiteout cloud, which is our standard mammogram, to it lights up just where there's a problem. And so this has been really quite revolutionary, and in the last couple of months, I would say that we've been doing it more standardly, and it's been making a big difference both for finding the lump and finding any other little lumps that we don't notice at the time and are responsible for recurrence down the road. There are some things that we're innovating. I'm not going to explain this picture. This is just to remind me to tell you that with Jeff Carson's lab, for example, who's an imaging scientist here at St. Joe's through Lawson, they've been looking at some of the different ways that you can image breast tissue. And one of the ways is with photoacoustic, which basically means, in my layman's understanding of physics, you shine a bright light at the tissue and it bounces off as an ultrasound wave, which you can capture and recreate with the software into a picture. And so there's lots of different ways, and some of the scientists are here also that work on that technology, both for screening, taking the picture from the outside, and also from when we take the lump out, screening the piece to make sure while we're in the OR that we actually got everything we wanted to get out. So there's some new technology that we're trialing, so we do that, and when we do these new trials, we ask patients every day as we're bringing through the OR, can I take an extra picture? We're doing this imaging, we're trying to develop this new hardware, and those are sort of ongoing projects. Let's look at some of the surgical things that we've been trying to improve. If you look at how patients are treated generally with breast cancer, you can either have the lump removed if there's enough normal tissue to leave you a breast to speak of, or you can have the whole breast removed. Same long-term outcome, same survival. If you leave the breast in place, there's a risk that it could come back, and so you need to add radiation. So we sell lumpectomy and radiation as a package deal versus mastectomy. We used to not speak so much about breast reconstruction, and the reconstruction rates were quite low until more recently, which I'll talk about a little bit later. When we were taking the lump out, we typically would just completely come down, take the space, close up the skin, and leave it to heal on its own. And I'll show you some pictures about how that doesn't always work out well. But now that our imaging technologies are being improved all the time, lots of patients are coming with what we call non-palpable disease. So you actually can't feel it, but it's in there somewhere and it was screen detected, which is perfect. Because that means it's really early stage and we've caught it probably before it spread anywhere. It's going to be simple to remove. The problem is I can't feel it, so I don't know where it is, so we have to localize it. So this is what we always did forever and ever. Put you in a mammogram on the morning of surgery, stick a wire in and kind of have it dangling, tape it to your chest, and you go to surgery, and then I can follow the wire. The problem is I can't predict exactly where the wire ends. I know where it came in, I don't know where the end is, and so you end up taking a lot more normal tissue than you need. And the cosmetic outcome is directly related to how much normal tissue you take out. You only need to take the lump and a bit of normal. You don't need to take a whole bunch of otherwise healthy breast tissue. And this done on the morning of surgery, if you can imagine, you haven't been eating anything in the morning, you're super nervous, you're kind of hungry, you're feeling a little faint, and they squish you in a mammogram for 45 minutes, and people were passing out. Annette Kornecki, the medical director of the diagnostic imaging for breast, came across this new way of localizing with these radioactive seeds. So these are tiny seeds, they look like half a grain of rice, and they have a tiny bit of radioactive signal in the middle of them. We use them to treat prostate cancer. So you might get 60 to 70 of these implanted throughout the prostate gland in a man who's having prostate radiation by brachytherapy. Instead, if we just take one of these, slide it right into the middle of the lump, then we can use our detector and find exactly where it is. So it doesn't matter where it got inserted. It doesn't matter where I put my incision, I know exactly where the lump is. It's like ding, 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 ding. So it's like child's play. And then I get a little picture, the radiologist shows me where it is, and I can put that into 3D and figure out where to take the lump out. There's my little detector. Then I take a picture. So the foundation purchased for us is Faxitron, which is basically an intraoperative X-ray machine. You slide it in like a little Susie cooker and take a picture of the lump, and then at least in real time you can get an estimation of how clear we are all the way around while the patient's still sleeping. So if you need to take a little bit more, you can do it and optimize your chance that you'll be successful in one go. Gives you a picture, something like that. There's my little 2 seeds in the middle. I'm pretty happy. And then the patient wakes up and goes home. If you look at surgically with the impact of taking that lump out, there's a little lump on the left side. So you can see this is the thing that I'm trying to take out. I want to leave as much gland as I can, so I'm going to lift the skin up. There's my incision, hollow it out. There's my space, close the skin up. And initially, it looks pretty good because your body heals a space by filling it with fluid. So you're thinking, wow, I look fantastic, like you did such a great job. I didn't even notice the volume defect. But the problem with fluid is that it resorbs. And these are some more dramatic pictures. I would like to say I don't have any patients that look like that, but that's probably not true. But you lose the volume and then it deflates and you get contour deformities and it tethers the nipple in a way that you can't fix. So there are lots of examples of where we extend the indication for lumpectomy where patients are probably better looking just to have the straight mastectomy all the way across and then have a rebuild. So these are really challenging surgical problems. And so I had the pleasure of going to Paris and learning a technique called oncoplastic surgery where basically use some of the plastic surgery tricks of remolding in the context of treating breast cancer. So it's like taking a piece of pie. You want to have a little sliver of pie, but you don't really want anyone to notice that you took a piece of pie. So you take the pie and then you kind of shift all the other pieces and it's a slightly smaller but really well-rounded pie. It's like that. So we lift the skin, we take our piece, we undermine it, we bring it together, and we close the skin. You have no defect, so there's nothing to hollow out. There's no contour deformity. So that's really new. So we've been taking that as a roadshow to the surgeons all across Canada just to show them how to do it. We do a hands-on course, 4 to 6 of them a year. And we show, for example, here where we just took a little piece, so the lump was right here, and her nipple was down here. So we just used it as an opportunity to give her a little bit of a lift. You didn't want anything dramatic. Took the lump out, and the lift was the filling of the space. And then you ended up with quite a nice look. If you have to take a bigger chunk, or sometimes you have to take a bit of skin, if you just close the piece, you'd be left with a little extra skin, so you can trim some of the skin as well. And then use that as an opportunity to bring the nipple back into center. And so there are all sorts of different little tricks to do. Here's an example of the scar. It does extend the scar a little bit, but that scar line will fade. And what patients will see to their eye is that it's nicely centered, the shape looks nice, and there's no contour deformity. You can even extend it more. So for example, if you think about patients that have a breast reduction, so large-breasted women, they usually in a breast reduction will lose at least 50-60% of their breast volume. So you're taking the entire half, the bottom half of the breast. So if the bottom half happens to have a cancer in it, it's perfect. You can take that entire thing, get huge margins. You can take multiple tumors, things that otherwise we committed to mastectomy regularly, and just trim that, wrap it around, and give them a lift. And these patients are delighted. They always wanted a breast reduction. We got our margins, we're happy, it's perfect. So I'll give you an example. So these are the types of breast reductions that you could see. Here's a patient that we did where we did it as a reduction, and she was quite happy, and it looked nice. It removed a ton of disease, and her outcome's excellent. So we've kind of contoured these new changes in the approach to how we do surgery. It's a little more complicated, it takes a little bit more time, but I think it should be considered the standard of care, and certainly is sort of a migration of knowledge from Europe over to now Canada and North America. If we have to do a mastectomy, now these approaches are going to reduce the number of patients in whom we need to do a mastectomy, but if we need to do it because there's too much disease that we can't leave anything behind, we can do breast reconstruction. And we used to do a terrible job at offering that to patients. Every patient should be entitled to a discussion to find out whether or not they're eligible, and then they get to pick whether or not they want that. That's how I see it. But the reality was in Canada, about 7% of patients post-mastectomy were getting breast reconstruction. I think because they didn't want to ask, and they didn't feel entitled, and the surgeon was busy and maybe not mindful of their psychosexual identity, and so didn't offer, and nobody talked about it. Now we're much better, so we're closer to 25 to 30%, I think much higher even here, where we have fantastic plastic surgeons who make it their priority to see patients in a timely fashion so that we don't compromise on the wait time in order to afford them the immediate reconstruction. And so we've really come a long way. There are also some new innovation tools that have allowed us to do it right at the same time, which looks much better. So I'll give you an example. It's a young woman that had delayed implant reconstruction. I don't know how well it comes across the screen, but you can see her scars all the way across. You can see that she has a shape, but it's kind of contour deformed. There's like a pucker here, it's like a stick out here. Naked, it looks artificial. She looks symmetric in clothing. So that used to be our goal. We'd like you to look symmetric in clothing, although you don't feel good about how you look naked. But that was sort of the best that we could do, because the reality is if you reconstruct with implants, you need to put it behind 2 layers of tissue. So behind the pec muscle and behind the skin. Well, there's not very much space. Our pec muscles are flat on our chest, so you have to stretch it out. So you put a deflated implant, then every week to 2 weeks you get inflated till you get to the size that you want to be. You have to let it sit for a couple of months, so that's been a couple months already. Then you have to come back and have another operation to swap it out for a normal actual implant. Then you can sort of create a nubbin of nipple, because we thought that the nipple was a lot of dense breast tissue and we were taking a chance leaving it behind. Turns out that that's not true. There's no evidence that leaving the nipple behind increases your risk unless there's tumor right there. And that when we lift it, it's more like skin than it is like breast. And so we've really, even in the last couple of years, redrafted the guidelines to recommend that we can do that safely. If you have a little extra paunch, as many of us do, you can rebuild it with belly fat, because really we're swapping fat for fat. And it ends up looking quite natural. It's soft, it feels like normal tissue. It's numb to patients. But if you look at this, so this was again a delayed, you can see, I can barely see it, but you can see the scar goes all the way around, and there's puckering laterally. So you kind of have this rebuild mound that doesn't have a smooth contour. But still, again, it's not bad, it's just not great. So one of the new innovations in the last several years is not cheap. It's a commercialized product, which is basically human donated dermis. So skin from a cadaver, they peel the surface off, they bleach it, and it kills all the cells, and all you're left with a protein structure like a scaffolding that they then package and sell at great expense back to us, and it creates a second layer. So you can imagine that at the time of surgery, you can lift the pec muscle. Now it's tight, so it's only going to go over part of the way, and you can use this material to go over the bottom half and then pull the skin all the way over again, and you did the whole job in one go. So you saved yourself an operation and about half a year of expansion. So this is really something that we've just started doing in the last few years, and it has revolutionized, I think, particularly in young women, how we treat breast cancer surgically, particularly with implants. Now, for women who are a little bit more ptotic, that means droopy. If you can imagine, after you've had kids and sometimes after menopause, things are hanging south. And if you fill that entire pocket with an implant, right? It'd be crazy. So we need to trim a little to make it reasonable to your shape, which means if we're going to trim, we can use some of that skin and the bottom half as our sling. So we use the patient's own skin, peel the top, it's already attached, it becomes muscle on top, this skin on the bottom, and then the top half of the above from the nipple up becomes the wraparound skin. And I'll show you what that looks like that. So those patients don't have nipples because we had to trim, but we can recreate them, but it gives you a really nice centered mount. And what's nice about these is the shape and the contour, the takeoff is all smooth. It looks really nice, I think. It gives a much better, much more natural look. And this really has been a very brand new change for us in terms of the quality of the care that we can afford to patients. So if you look at a young woman, so a lot of young women who carry the gene mutation that puts them at really high lifetime risk of developing breast cancer, these are women in their 20s typically, have a lot of life years ahead, some single, so it has a really big impact on their sexual identity. It matters how they look. And so now, because we can use that muscle and dermal material underneath the skin and can leave the nipple, we can make the incision along the fold. So her scar is here. You don't see it because it's under the fold. And you just peel the whole skin back. And we learned how to do some of these techniques. I went down to New York and collaborated with some people that were doing this brand new way of cutting the skin so that it didn't get damaged in this way. And then we've been adopting it with great success. I think it looks fantastic. And there's another post-op patient where you can barely see a little bit. She's just fresh post-op, so you can sort of see a bit of the scar here. But really that'll fade and it ends up looking quite nice. And you don't have that buckle that you were having from the other ways of doing it in a delayed fashion. Okay, what about some of the other beyond surgery, beyond local treatments to reduce the risk of recurrence? If you have breast cancer, particularly if it's spread to the lymph nodes, you're going to get recommended chemotherapy. Chemotherapy is basically toxic chemicals that are intravenous, usually once every 3 weeks, 8 times. And so it's spread out over 24 weeks, which is almost 6 months. And it makes people feel sick. Most people don't vomit, but everybody feels tired. You think you would lose weight. Actually, people generally gain a little weight because you just feel gross enough that you want to just lay around, eat chips and watch TV. And if you do that for 6 months, you know what's going to happen. But it does reduce the risk of recurrence. In the last decade to decade and a half, we've really grown a lot of the complex targeted therapies, which we call biologics, which are antibody drugs. Antibodies are proteins that your immune system makes. They kind of look around and they identify something that's not right. They bind to it. And as soon as it's bind, it's like having a flag on that. Kill that, kill that, kill that. And then the non-specific cells just come and eat it up. So one of the proteins on the cell that we look at is called HER2. The HER2 protein gets overexpressed. They're like feelers. They're supposed to feel how many cells are around me. If there's too many cells, I shouldn't grow so fast. I just need to mind my own business, keep to my space. But the tumor cells, they give themselves extra copies. So it doesn't matter who's around. They over-replicate, and grow out of their space. And so those are fast-growing, more aggressive cancers. And so we can give them this antibody drug. Now, it so far works best in combination with chemotherapy. So even if your tumor is small, if it's HER2 positive, you're going to get chemotherapy followed by Herceptin, which is once every 3 weeks, IV for a year. So you can see this thing is starting to become really time-consuming. And for people who work, this is a really big deal. But it's very effective, and there are all sorts of other ones coming down the pipeline. Super expensive drugs, which are really innovative, but ideally built to target exactly those cells and kill only those, and not the lining of your gut that gives you diarrhea, not the follicles that make your hair fall out, although all those things do still happen. The other two proteins that we look at on the cell surface are for estrogen and progesterone. Those are the two female hormones, and most tumors are sensitive to those hormones, meaning if you take the lump out, if we give you an anti-estrogen tablet, it'll block that protein and target that cell, and that cell will basically starve to death. So that we give every day as a tablet, 5 to 10 years. The side effects from that are predominantly joint ache, but most people tolerate it, I would say, pretty well. It's the chemotherapy that I think people find pretty challenging. So as we get better at targeting specifically, we can move away from the non-specific chemotherapies that make people sick with unknown effect. So chemotherapy is like life insurance. You don't know if you're going to need it, but you're buying in. So you treat everybody so that the few people that do have those circulating cells that escaped your tumor, that are looking for a home, are going to float in your circulation, and so is your chemo, and it's going to kill them and reduce the risk of it ever coming back. But a bunch of people are taking it who never had those circulating cells, are getting the side effects and didn't need the chemotherapy. We just aren't smart enough to know who those people are. But hopefully with some of these innovations, we can get smarter. What we're realizing is that a lot of cancer is related to the immune system. And in the last, I would say 1 to 2 years, this field of what we call immuno-oncology, using the immune system as a treatment for cancer, has exploded. It is almost impossible to keep up. It's really innovative. There are huge markets in the drug industry to develop targets that prime the immune system. And one of the reasons is that we realized that cancer cells, they have these proteins on them, as we mentioned, get recognized by your immune cells. So there's all sorts of different immune cells that have different jobs in the body. One of them is supposed to regulate recognizing you as your own cell. So you don't want your immune system floating around and killing every one of your own cells. You want your body to say, no, that's me, that's a normal healthy, bad bacteria, normal healthy, bad cancer. So there has to be a break that says, whoa, don't kill that cell. And that's what we call the checkpoint inhibitors. So CTLA-4 is an example of that. So it's a protein. It says, oh no, I see that, that's my own. Don't kill that, except that was a cancer cell. So the cancer cells are learning to give themselves these proteins that say, oh, don't kill me, don't kill me, don't kill me, and it hides under the blanket of the immune system. Even though the immune system is fully functional, it's got these breaks going. And so these new drugs stick to this, I'm okay, this is my own cell, so that it doesn't bind to the cancer cell. And all of a sudden, the cancer cell is vulnerable and gets targeted for a kill. So we really learned a lot about the immune system and its role in how we can take advantage of that and take the brake off, basically. The PD-1, or programmed death cell, ligand 1, is another one that's like that too. So those are the two sort of big ones that are coming. So here's this guy. So he's like, look, I'm a cancer cell, that's okay, don't kill me. And if you block them, then it can't bind. So it says, well, I see that cell, that ain't right, and then go ahead and kill it. So we have been exploring how to use these drugs in all sorts of cancers. Right now, they're mostly in trials for what we call metastatic breast cancer. So when patients have spread everywhere else, probably because we're sort of at the limit of our options for those patients, to be truthful. So we're ready to explore anything that might work. Also because there's multiple spots. So if you can try to target it, you can see if it's working or not, because they still have cancer in different areas, and we can see if it shrinks. But ideally, we'd like to move beyond that, because in my mind, this sort of thing is like creating an in situ vaccine. So it's like vaccinating you against your own tumor cells that have gone wrong, so that in the future, if it's like a virus. You've been vaccinated against the flu. If the flu ever comes, you recognize it, you bind it, you kill it. The same way with these cancer cells. So we need that specific cancer cell to be targeted, removed at the survivable stage so that later if it floats around, there is no chance for developing metastases. That's what we're hoping to do with these drugs. The problem is they make you sick. So what do we do? And they're toxic, they're difficult to tolerate, and they probably work best when in combination. So patients probably need to take the anti-PD-1 plus the CTLA-4, and that's getting crazy. If we're making people sicker, then we're making them better. Because if you can imagine you take the brake off your immune system, it recognizes everything, doesn't it? Again, the cancer cells, also your liver cells, you can get hepatitis. Your lung cells, you can get pneumonitis. Your pancreas cells, you can get diabetes. So all your autoimmune cells, all of a sudden your autoimmune diseases are going to flourish. So we need somewhere to recognize the cell, but not be so crazy that we're going to have autoimmune diseases to contend with, swapping one problem for another. And so we're working at different ways. And one of the trials that we're just at the writing stage for here is looking if we can do it in a different way. So instead of the really toxic anti-CTLA-4, we found in animal models that you can actually turn that protein off with just a low dose of a chemo that we already use for breast cancer, but in a super tiny dose. And we've learned that about different drugs over the years. For example, antidepressants at low dose are very effective to reduce hot flashes. So they have dose-specific effects. And so if we use this chemotherapy that at high dose can give you that numb hand, foot kind of nerve damage that you get from chemotherapy, at super low dose just takes the brake off the helper cells and is like an anti-CTLA-4 drug. Super easy to tolerate. So we're going to try, we've asked the drug company for some drug for the anti-PD-1 that we could give in combination with this tiny little dose of cyclophosphamide. And then we're going to see if we can make a difference. Then we've sort of found a cheap Canadian's version of a super expensive remedy. Another way that we've been trying to change what we already do is looking at radiation. So radiation is always given after breast cancer surgery. So it just has always been that way. I don't know why. I think because initially surgeons were worried about operating in a radiated field where the skin might be kind of damaged. Is there a higher risk of wound infection? Is it going to be harder? Let's just do it after. The problem with doing it after is your lump is removed and you don't know if it worked or didn't work. So radiation typically is every day, Monday to Friday, no weekends for 5 weeks. So it takes you longer to park than to get your treatment, as I always tell my patients. You'll lie on the table with your arms, I'll show you a picture, for about 10 minutes and you'll swear the thing isn't on. But you'll slowly get a square sunburn that I'll show you. And the only way you know if it worked for you is if your cancer doesn't come back. So that to me seems pretty archaic given how sophisticated we become with our imaging to find the cancers, how sophisticated we become with tailoring treatments with antibodies, and we just are kind of randomly giving people a sunburn and hope it works, fingers crossed. So the best way to figure out if there's genetic or tissue-specific markers to predict who it works for is to treat it pre-surgery. So when the lump's still there, you give them the radiation, you have tissue before and after, you can check a change, and you can develop some predictive markers that you can test for now in new people to say, hey, if you have this kind of DNA sequence, you're going to respond well. Perfect, we can give it to you after. You're not going to respond well, you should have a mastectomy and reconstruction, instead of waiting for the patient to recur. The other problem is the burn is bad. And then there's lots of worse pictures than that. But just to give you an idea, it heals. It doesn't look the same afterwards. It's quite tight, or what we call fibrotic, scarry, leathery skin most times. And it can really contour, deform, or change the shape of the breast. But it really effectively reduces the risk of cancer coming back in that breast if we leave some portion of the breast behind. So it's important. But the thing that we've noticed is most of the recurrences, probably 90% of them, occur within a centimeter to centimeter and a half of our lumpectomy. So we really have sort of shifted to say maybe we don't have to radiate the whole thing. Maybe we just need to target right to that spot. And if we just need to target to that spot, maybe we could just do it up front. This was inspired for me by this study. So I promise I won't show you too much details, except I want you to notice these two lines kind of stay together and this line sticks out. This study was done in the 1970s in Sweden. I just stumbled across it. Nobody talks about it. I find it particularly elegant because it was in the days where you didn't have chemotherapy, you didn't have hormone therapy. Everybody got a mastectomy, and they randomized almost 1,000 women to getting radiation before your mastectomy, after your mastectomy, or not at all. And this is your after mastectomy, and this is your not at all. They're not different. And this is your before. There was a significant improvement in survival with just changing up the sequence. Why is that? Everything else was the same. And so that's what made me sort of think, there's got to be something to radiating when the lump is still there. I mean, it certainly explodes cells. If you explode cells, one thing we know about the immune system is it all of a sudden unleashes a bunch of proteins that your body can recognize that maybe it didn't recognize when things were all nicely hidden and tucked away. And it creates maybe this in situ vaccination that we're hoping for. And so that, in conjunction with that, led us to do here a study where we gave the radiation with chemotherapy, because some of the chemotherapies actually make the radiation more effective before surgery. So these were women with stage 3 bigger tumors, most of them young, and they got their chemotherapy and radiation up front. So we had to get Health Canada approval and get all sorts of different regulatory processes in place. You can imagine changing how we do things is a big amount of paperwork, and it's not without its risk. Some patients got some lung swelling they needed a short course of steroids for. And these women contributed a lot. They went through serial pictures, serial SPECT-CT images. They went through serial biopsies that they didn't need. And they did all of that because they were as committed as we were to making a difference and finding out whether we could change the outcome for these patients. And there was a 15% improvement in survival when we did it that way. The other thing that we had noticed was that the patients who completely cleared the tumor, where there was none left by the time they had surgery, had a great outcome. And we significantly increased the number of patients that we could achieve that for. And of the patients that had a complete clearance, none of them have recurred. Whereas for patients that didn't have a complete clearance, by year 3, 62% of them were still alive. So it makes a big difference. But it's complicated and it involves chemotherapy and there were side effects. So we were thinking, how can we do it, optimize the benefit of perhaps priming the immune system, not get into all the grief with the chemotherapy, and we could maybe do it with a short course or a lower dose. So we started with early stage breast cancer, and it took me literally probably a year to figure out how we were going to do it when the radiation is delivered lying on your back, but the MRI that we were going to use to guide it is lying on your front. So that is a hard problem. But ultimately, we realized that some centers were doing this radiation lying on your front. And then we could overlap the images because the radiation is planned on a CT scan, which basically takes pictures of your body. It recreates the image, and the radiation oncologist draws a picture for the medical physicist to say, this is where I want the radiation, this is where I don't want it, don't give it in the heart, don't give it in the lung, although you get some dose there, and they make a plan how they're going to deliver the beams so that it all goes through there, not there, not there, not there. And if we can overlap that with an MRI, which shows an exquisite detail exactly where the little lump is, then we can radiate it all up front. Otherwise, if you wait till after, because it's a bigger area, your cut, the space, the healing area, you have to deliver a lot more radiation. You can't give all the radiation up front to a big, huge area, you get a big burn. But if you target it exactly just to the spot when you know exactly where the spot is, then you can deliver it all at once in 10 minutes instead of 5 weeks. But you need to be lying on your front. So we got a small grant locally here and purchased these little pillows here, which were like $5,000 each, and made our own. And in classic Canadian fashion, we home crafted it, wrapped it up, got it all approved, and then we were on our way. And it was a new learning curve. It hadn't been done in London before, but it made a huge difference to patients. So a lot of patients, we have a pretty big rural and catchment area. That means that London and area is populated, but it serves southwestern Ontario, which is quite rural. People can travel from Owen Sound or from all sorts of areas for hours. And so if you want to travel 2 hours here, 2 hours back, every single day for 5 weeks, so you know what, I'll just have a mastectomy. but you didn't need to. But you're picking because it's too much and you have to work. And so you can say, well, maybe I can't come 25 times, but I can come once. And so I think this offers for some people a really great alternative. And the other thing I really liked about it was that it allowed us to bring forward the breast lying this way in a hanging fashion, and you get radiated from underneath and away from the heart and lung. So you're not getting the dose to your organs that you're getting if you kind of go on an angle through your normal tissues to hit the target. So for lots of reasons, this study has a really great uptake. Patients love it, so do I. And we call it the signal trial. So this was the step one, signal one, where we wanted to just to prove that we could do it. We needed to get the technologists to learn how to deliver radiation lying forward. We had to figure out how to make the MRI work. We needed to find tumors that were kind of in the middle, not too close to the skin, not too close to the chest, so we could deliver the whole dose at once because we didn't want to compromise. And we need to figure out how to calculate the difference. How do we make it the same amount in 25 times as in one time? And so we calculated that out. I mean, if you think from a health cost effectiveness perspective, it's like 95% cheaper, right? Because you only have to come once instead of 25 times. And the other thing I liked is that we could be more specific about how much we don't want the radiation to get to the skin. And that, I think, makes a big difference if you really dose up the skin like you have seen before. And it was just a new way of thinking. I think it was just standardly easier to radiate the whole thing and not think about the skin versus spending like an hour drawing out the skin where you don't want the radiation dose to go. But because it makes such a difference, particularly young patients, that's what we did. And these are some pictures just to show you the difference pre-op and post-op. And it's going to be hard to find where actually her scar is here. I don't know if you can see that. This is at 3 weeks post-op. And you can see the shape is nice. You don't have a big contour. It hasn't pulled the nipple out. And it persists at 6 weeks. And this is prior to radiation, and this is just after surgery and radiation combined. She's not red at all. So they come to surgery, they're not burned, they're nothing. They're delighted, actually, and it's quite effective. And this is another picture. So this picture, I just like to stay humble and show a bruising. The scar is a little bit more visible. So even there at the 3 week mark, you still don't have a big contour deformity, and that's lost here. You can barely see the scar at the 6 month mark. And if you ask patients how they feel, so this is sort of a standardized way to get at how patients feel about their look. We would get them to rate their cosmetic score. So we rate out of 4 and they rate out of 4, pre-op, post-op, 6 months and a year. And patients were uniformly very happy. So there were some people that didn't feel that they were excellent even before we did anything. But we did. We thought they were excellent. And then we were a little harsher to ourselves post-op. But then back at 6 months, everybody's feeling excellent. And if anything, their quality of life scores were higher immediately after surgery and treatment than they even were before. The next step beyond that is to say, okay, now we've shown that we can do it. Let's apply it to patients with bigger tumors. So the bigger tumor, I said you can't radiate the whole thing because it's going to be close to the skin. And if we spread it out in the normal way where it's safer over the 5 weeks, before surgery, that's like a 5 week plus you take a month to heal. That's like 2 months of delay. So raise your hand if you want a 2 month delay with the tumor in place, right? Not very many people. So we had to figure a way where we could still get the priming effect of the radiation without the big delay, still without the burn. And so we sort of come up, I asked the physicists, who are very cool people, to calculate a way, this is sort of what they call generate a plan to figure out how they're going to radiate some portion. So I said, you don't have to radiate the whole thing. You just have to radiate some of it. You just have to kill some of it, let the proteins release, get the immune system recognizing it, and then we can move on. And we can do it in 1 to 3 doses because we're still exploring whether 1 or 3 is more immune priming. That's an ongoing study. But they can still do it and avoid the dose to the skin. So they're specifically saying the dose cannot go past that. And so we're going to launch that in short order. And I think that will be really sort of the most informative, where we look at these higher risk, bigger tumors. And these patients We can do a biopsy before and after, so we can still look at the difference. We can look at what it tells us about the tumor. We can use the MRI that we're now going to overlay on a PET. So St. Joe's has a PET MRI machine where you get both images at the same time. And the PET scan tells you how things function. So there are some IV contrasts that you can inject that are basically radioactive sugar, and tumor cells eat it up like crazy, so it lights up. Right on top of where the MRI shows the lump is. So it shows what's active. And we can use that to target the active parts. So we don't have to just radiate some part of it that maybe is dead in the center already. We can target a really active part using the PET MRI. And it also has other contrast agents that we can explore with our imaging scientists that are looking at new ways to get better contrast agents. So, okay, sure, if you want to study that, we have patients coming through anyway. We can try different drugs, see how much more informative this injection is over that injection, with a thought that ultimately we can radiate some part of it and they'll go on to chemotherapy or to surgery as they were going to normally. So I'm not very good at these acronyms, so I call this the control trial, the checkpoint inhibition during neoadjuvant, which is preoperative, trial of radiation on more advanced breast cancers. So I think this is going to be pretty innovative, and this we're making a request to the pharmaceutical agents to provide us with the drug, and it's going to be a big undertaking at multiple centers so that we can look beyond our borders. So we've collaborated with Montreal, with New York, and a few other centers, Ottawa, where we're offering for them to enroll their patients if they wish, and it gets us more answers quickly, and I think the more minds that come together, the faster we come to these answers. This is the schema. It just basically, I include it here to show you, so there are stage 2 or 3 high-risk cancers, so big cancers, fast-growing problem cancers, where we do a biopsy. So you see they're having extra biopsies that they wouldn't otherwise need to have. These women are courageous, brave, and gracious. They give us extra samples all the time, and it's not easy for them to go through, but they know that it's important. They go through the radiation plus or minus the immune drug, and then they can go on to, we might even just split this to just go on to your chemo and then surgery, or go on to the chemo plus the continuing the immune drug. We're still debating whether or not that has scientific merit. So the London Tumor Bank, which we started here and has been really quite sustained by the foundation, has contributed to a lot of these research innovations by having the platform to collect these samples. So if we're looking at DNA and the genetic product of DNA, which is RNA, which makes the proteins, those things degrade quickly. So you have to process, you have to flash freeze the samples in liquid nitrogen. You can't just sit on it. You can't put it in saline. You have to take the blood, spin it down, freeze it right away. Because if you do that kind of thing quickly and effectively, then you have all the rich information that you need to have really elegant questions answered. But to do that, we have to have the facility. But what's nice about having that and having the structure where patients are approached usually at the time that they're having their biopsy. So they're already with the needle in place, and we're saying, you know, you're having these biopsies anyway, do you mind, could we take an extra piece or two and draw some of your blood? You're already kind of having the needle, and 92 to 94% of patients agree. Considering it is their most anxiety-provoking day of their life, I think it's incredible, and it gives us really rich data for which we can offer to other scientists. It's really hard to get grant funding to do research in Canada, but also in general. The success rates for big grants are usually around 8%. So, and these are among very valid, very important studies. Only a fraction will get funded. And so they have to really be at the advanced stage, but to get the answers at the advanced stage, you have to have money to get the samples to get the answer, but you can't get the answer until you have the money to, you know. So what we're trying to do is to say, look, we will give you the tissue, the data, the information for you to get your hypothesis sorted, answer your questions, come with some preliminary data to the granting agency, and then your success rate is much higher because you know what you're doing, you have proof in principle, and what you're doing actually matters, and you can tease out the stuff that actually goes nowhere. So This is a great platform to do that. Additionally, because the patient already still has a tumor in place and you took a sample when they got diagnosed, you have to wait a couple weeks before you see the surgeon when you can make a plan anyway. During those weeks and then the ensuing few weeks before you're waiting for your surgery anyway, that's a good chunk of time where we could do something. We could test a new drug. It's not enough to make you sick. It's not enough to make a difference. It won't make the tumor shrink, but we could take a sample after at surgery time and we would have a before and after, and we could see who it works for and who it doesn't work for when you're kind of waiting anyway. And we call those window of opportunity trials. So it's a window of time where there's an opportunity where the cancer is still in place that we can actually answer at the genetic molecular level. I could predict this is going to work for you, the drug that you're going to take for 10 years, because we did a sample before and after. So even things like tamoxifen that we give to women for 10 years, which has a small but real risk of endometrial cancer, a risk of blood clot that could kill you, those drugs we could say, look, why don't we just give it to you for 6 weeks before you're having your surgery anyway, and then we can test who it works for and who it doesn't work for, and then if it doesn't work, we'll give you something else after instead of saying, well, I hope it works. So those window of opportunity trials we can only do when we have the platform of collection. But what's nice about it here at St. Joe's, and I mean in the Canadian world in general, is it's a sort of a flexible platform where everybody works together. And so there are other trials where they're looking at different things, where we say, we'll help you. It's not the normal stuff that we collect, but we can help you write the study so that you actually specifically answer the question you intended to answer, because scientists are great in the lab, but they might not always know how to design the study that actually gets the answer that you want. And you don't want to waste people's time. I think that's really rude and disrespectful, and you have to be really precious about that resource. And so you want to frame it right. There's a lot of paperwork that goes into designing a trial. You have to get Health Canada approval. It's a regulatory nightmare of sorts. And so we're kind of used to it. And so we're trying to be the platform that helps the scientists. I don't know, I just have this question and it seems to work in the lab. Let's just test it out. And so there are lots more than these, but these are some examples of collaborations that we have going on right now with different scientists where we've helped them collect samples. So Mashmi Bhattacharya is at Rutgers in New Jersey, and she's looking at a specific protein for tumor cells that don't have any of the markers we talked about. They don't have HER2, so we can't use Herceptin. They don't have estrogen and progesterone, so we can't use a hormone blocker. Those people are in big trouble. They get chemotherapy, but it's a very aggressive kind of cancer. But it seems to be in those breast cancers that a protein called kisspeptin, which normally is used to turn down the development of cancer, in triple negative cancers seems to be turned up. And so that might be a good target. So we might be developing now a new target that tells you, if you measure the protein level in your circulation, yes, that the cancer is there, or that it's spread, or that we could actually create a blocking protein drug. With Dr. DeMaria and Cornell, we've been collaborating with these signal patients, so the pre and post radiation samples, to look for how we can prime the immune system. Because the next thing I'd like to do is to see if we can't make all the immune systems very sensitive to these immune priming drugs. All the cancer is sensitive to immune priming drugs. It seems like probably 20% of them right now are immune primed. But what if we radiate them? Could we turn that number up? Could we make what we call cold tumors, not very immune priming, into hot tumors? And so she's looking at different ways, very complex platforms, very complex ways to look at the genetics that we don't have, the types of equipment we just don't have in Canada, and they're doing that in collaboration with us. We're working with Dr. Williams, who's got a new microparticle protein that she's looking at. And microparticles are sort of all the rage now. They basically means tumor cells, when they kind of shed, some of them break up into little chunks of pieces of wall of tumor cells float around. And they don't do anything bad to you, except that you could use them as a marker to detect whether the cancer has gone away or whether it's come back. And so it's a really interesting sort of new field. And so we've been collaborating, providing some samples for her to test, and she's at UBC. There's another protein called nodal protein that we've been working with Dr. Posovit for. So this protein is the protein that seems to turn on the cell. Remember the cell that the cells are in the picture where the cells are all malignant looking, but they're still in the milk duct. So you can't die of that disease. And then the next one, it starts to migrate through. Well, the nodal protein seems to be responsible for making that transition. And so if we can block that, then we could catch patients in the non-invasive stage and prevent them from getting the migration where cancers can actually grow, spread, and make a home somewhere else. With Dwayne Johnson, we've been looking at something really interesting. Dwayne Johnson is not a cancer researcher, but he had stumbled on some work where he saw that the sympathetic nervous system, so the nervous system that gets all revved up when people are scared or fearful, that nervous system has different proteins that turn it on or off, and that seems to be really turned up in breast cancer specifically and not in normal breast tissue. So is it that those breast cancers are being fed by stress hormones? Does stress cause breast cancer? And this is going to be the one way that we start to look at that question, which people always feel like I was really stressed and maybe this is why I got cancer. This is going to be one of the things that I think will be quite innovative. Masumi has been looking at, in Manitoba, has been looking at anti-inflammatories, so COX-2 inhibitors that people use for arthritis. As he said, different drugs can be effective in different ways at different doses. And it seems to be that there are versions of these drugs that might actually be cancer blockers. So we've been sharing a lot of samples with her. And then Dr. Weeb, who's a retired physiology professor here at Western, has been looking at some of the saliva and blood hormone levels, some ratios, not just the absolute amount, but the ratios of one versus the other, in the nipple fluid. So oftentimes after women have had a child or have breastfed, if you squeeze their nipple, you can get a little droplet out. Some people leak a little bit spontaneously. And if you can collect just a little droplet of that, get a little piece of saliva and a little bit of blood, then we can test to see whether we can develop an easy diagnostic test for cancer, maybe at the early stage where it's still inside the milk ducts. So we're just starting those ones. One of the things that I'm excited about in collaboration with Gregory Reed, who's a probiotic or a microbiologist, a researcher of bacteria here at St. Joe's, is looking at the role of probiotics in breast cancer. So he was the first DocTalk speaker, and I think he spoke to this. There are two studies that I'm just starting with him. One we're ready to go, and the other we're just finalizing. But his lab and Camilla Urbaniak, who was his PhD student, was the first to identify that milk ducts actually have bacteria in them. And we used to never think that that was true, because that's crazy that sterile tissue actually grows bacteria in it. It doesn't even make sense. And yet she showed it quite clearly, and in a quite elegant study, showed that there was a difference in the kind of bacteria you had in cancer tissue versus the kind of bacteria that patients had who didn't have cancer. And so maybe some of these cancers are what we call pathogenic or cancer-causing. They're irritating. We know that things that cause inflammation cause cancer. So people that have chronic inflammatory wounds, chronic burns, are at higher risk in that spot of developing cancer than people who don't have chronic inflammation. And the best example of that was Helicobacter pylori. Helicobacter pylori is a bacteria that lives in your stomach. About half of the world is colonized with Helicobacter pylori in their stomach. And it is the most common cause of chronic irritation or inflammation, what we call gastritis, which can lead to stomach ulcers. So when I started my residency, having gastric ulcers that perforated, that bled, that caused pain, that caused scarring and blockage of the stomach were common fare. So we were doing these operations, removing stomachs every day. And then somebody said, well, maybe there's bacteria that's causing the inflammation, and people thought that was ridiculous. That was heresy. I can't even believe that you would think a bacteria would live in acid, and probably got mocked all the way home. But persisted, and sure enough, identified a strain called Helicobacter pylori, which does live in the stomach just fine, but causes chronic inflammation, is responsible for gastritis, perforated ulcers, and cancer. And once that was identified, we can eradicate people with an antibiotic that lasts a week in combination with an antacid that you take for 6 weeks, the simplest ever common antibiotics, eradicates the bacteria, and we've actually seen a precipitous drop in gastric cancer to the point that it is rare. You can't be a stomach cancer specialist here because you hardly ever get any work. But it's a good problem. And so we're proposing that the same is true for the milk duct. We'll see. It might not be, but I think there's something to that. And wouldn't it be interesting to see if those are the pathogenic bacteria that are actually causing chronic inflammation in some patients and predisposing them to gastric cancers or to breast cancer. So what we're going to do is start with our high-risk patients, and we're going to give them a probiotic. First thing we want to do is to identify whether taking the probiotic actually changes that bacteria, or if that's you have what you have. But it seems to suggest that when you actually take a probiotic, you could change the flora favorably with just a simple probiotic, which most people take anyway. So we're the first to be exploring that, but I can tell you it's becoming vogue on the international stage, where we were just at some conferences that they are starting to look at probiotics in general for cancer. Specifically with these anti-PD-1s and these chemotherapy drugs, we see that patients develop a resistance to cancer, they progress, and then they go on to die of their disease. And we always thought the tumor cells were the ones that kind of didn't respond anymore, and it didn't work for your cells anymore. But actually we're finding now that some of these are related to the bacteria in your gut, and if you take a probiotic and change the bacteria in your gut, the tumor responds to the cancer treatment again. And so there is a lot more at play than we thought, sort of in our naive understanding of it must just be the one indirectly impacting the other. And so we're going to look to see whether giving somebody a probiotic actually does change the bacteria, and then long-term whether it makes a difference to their breast cancer risk. The other thing that we are just talking about is whether or not when we give radiation to these patients, we're zapping them. Now, if you think of the standard radiation, so the 25 treatments spanning over 5 weeks, you're probably getting some immune priming, as we talked about, from the cells dying and the immune system coming in, but then you're radiating those immune cells, and then they come in, and then you're radiating them, and then they come in, and then you're basically killing off your response to the cancer. The same is probably true with the bacteria. You're killing them, and killing them, and then what happens when you take an antibiotic, for a sore throat or something, and then all of a sudden you get a different kind of infection that you don't like? That's the same thing. You don't know what's going to regrow into that space. So what if we gave the probiotic during that radiation treatment and see if we can't just keep the healthy stuff there and the bad stuff out? They compete for space. If the space is full, they're going to go park somewhere else. And so we'll see. The other thing that we want to look at are quality of life issues. So when we have patients with breast cancer that spread to the lymph nodes, we need to remove their lymph nodes. The surgical consequence of removing the lymph nodes of the armpit, the primary draining site of anything off of that breast, is that that's the shared lymph drainage of the arm. So now that lymph fluid, which is basically your circulation going to the cells of the arm, your cells eat up the sugar and the oxygen and then dump all the garbage back through the lymph channels that goes through your lymph nodes, back in your circulation and back around again. But if your lymph nodes are removed, it doesn't know where to go. And so we leave a drain, and it falls into the drain, and then over the ensuing week or two, it makes tiny little lymph channels to connect to some other lymph nodes higher up underneath your clavicle bone that assume the regular day-to-day job, but might not be strong enough if you get a big infection, you get a big cat scratch, a festering wound, your body sends a bunch of immune stuff. Those little guys can't drain it, your arm stays permanently swollen. It waxes and wanes, but it never goes away. So for most patients, it's not as bad as that. The patients that have this amount of lymphedema would wear a sleeve. For example, we've seen hands, the wristbands, and the whole sleeve. But it's a real nuisance. And it really does increase the risk of that arm becoming recurrently infected. So we have always believed that you should never get your blood pressure measured on the side, that you've had your lymph nodes removed, you should never have an IV. There is no data to support that. In fact, there is data to support that it does not make a difference. But it is so ingrained, it's ingrained in every nursing education. It's just common fare that if you've had lymph nodes removed on that side, then we do the other side, which is not a huge deal for blood pressure. But if you're getting chemotherapy for now a year and some, I can assure you you're going to run out of veins in this arm. And it becomes a really big treatment problem for patients. And so we need to answer this question honestly, truthfully, and accurately. Because it's not a cancer treatment, but is a very big quality of life issue. So we're proposing this trial. We're calling it the REACT-B trial. where we're randomizing patients to using the arm or not using the arm. Again, it's a stretch for patients. It's a leap of faith to believe with us the data that supports that it doesn't make a difference, but we just need to prove it. So we're proposing that we give patients armbands to say, I bust myths, use this arm or don't use this arm, and then they keep track, and then we'll see the difference they can make. But these kind of things could only be possible if we have sort of the centralized program that we have at St. Joe's, where all the patients are being funneled here for diagnosis. We get their biopsies, we have their data, we can offer them a variety of trials, and patients get the right and the opportunity to participate in anything that they feel benefits them and or contributes to science as a consequence of what they have to go through anyway. And so we're really excited about all the different things that are sort of coming down the pipeline. And that's it. Thanks very much for your time.